I'll start my talk on corneal allogenic intrastromal ring segments or CARES, which is a technique I started around 2025. And I must say that I do have a patent pending for special Trifines devices and processes used to create these segments. Let me start my talk by telling you the reason why I actually started out this technique. It was because I was doing many intacs and I was pretty happy with the visual results, but I used to come across these cases every once in a while, and this really used to put me off doing this procedure because you would come across, as any person who does large volumes of these cases would see, you would get melts, superficial melts, necrosis, extrusions, sometimes even intrusions into the anterior chamber. Even acute hydrops has been reported post intacs, and also sometimes infectious keratitis. These are the major complications, but of course also a lot of minor complications like haze, intrachannel deposits, and so on and so forth. And the reason I thought was to avoid these complications, and this is basically what I started, which is basically doing the same ICRS technique but using allogenic segments. So if you look at this, this is a trifine that I had designed, and it's a double-bladed trifine. And basically, it cuts out this ring of donor tissue. Now, the tissue could be any kind of allogenic tissue. The one that I am currently using is basically a donor corneoscleral rim. And you can see the first thing that I do is remove all the epithelium from the donor stroma, and then remove it from the artificial chamber, remove also all the endothelium. So it's a de-epithelialized and de-endothelialized stroma now, cornea now. It's just basically mostly stroma and probably some amount of Bowman's membrane and predesmates layer. So now once that is done, it is cut using the double-bladed trifine, as you can see here, and we remove this ring of stromal tissue, which is what we get, and we cut into two pieces. And these are simple cataract surgery instruments that I've devised. This is a keratoconic patient's eye, and the femtosecond laser channels have already been created. It's very simple to just push these segments in. You would think that this is cornea and it's difficult to push it in, but really it's really simple. You just have to kind of design simple instruments right there, which are already with you in your OR, and can easily push these into femtosecond dissected channels. And if this patient has also got, if the patient has also got progressive keratoconus, then you can also combine it with a cross-linking at the same sitting or in a subsequent sitting. So these are just some post-operative images, and you can see these are the CARES segments, very quiet and lying absolutely inert and very biocompatible, obviously, because it's corneal tissue within the patient's cornea. And you can see also in the slit image that the depth of implantation, also as you see in these anti-segment OCT images, that the depth of implantation is around 50%. So it's really a much more superficial location than you would do for intacs. And we've seen that we get very good results with this technique. We published it in 2018 in the Journal of Refractive Surgery, and we found significant improvement in almost all the parameters: uncorrected and best corrected visual acuity, spherical equivalent, topographic astigmatism, keratometry, steepest case, anti and posterior best fit spheres, and so on and so forth. And this was basically just the first page of our published paper. What we found was that many of the disadvantages of synthetic implants, which included all the ones that I mentioned above, were avoided by us. You can see this this picture, which I have borrowed from my chapter in the coming Janov and Duker edition. You can see this is an intacs, and you can see this is also in this case lying quiet, but notice its posterior location. And here is a CARES, and you can see that these are more broader channels and also more superficial location. They are larger segments and also lying very quiet. Now, the one thing about synthetic segments is that you cannot implant it in very thin corneas. If you have to have a minimum of at least 450, some say 400 in the zone of implantation. And also you don't prefer to implant this in very steep corneas, more than 50 adapters, because then those are the corneas where you can where the risk of complications really goes much higher. So that's one disadvantage of intacs, that you cannot put them in very advanced cases. The other thing is that you have to have deep implantation, because you have to have sufficient cornea overlying the segment to prevent complications again. So the effect may be limited because of that. And of course, also you need FDA approval, at least in the US, for different thicknesses and different arc lengths. So you would have to, you are kind of constrained by the arc lengths that are available for you to use. And in other countries, you need to have a large inventory of segments of different thicknesses, different arc lengths, different base diameters, and so on and so forth. Whereas when you look at CARES, it's corneal tissue, so it's absolutely biocompatible and biointegrable. So it avoids the complications that people dread from intacs. You can also implant it in thinner and steeper corneas. After all, in DALC, you're putting cornea straight over over about 15 to 30 microns of about 30 microns of tissue. Here you're putting it into 300 or 400 microns of tissue, that's really much more safer than putting an intact. You can also implant it in thick and thick corneas. You can put in less deep corneas, so that includes all your mild and early cases of keratoconus as well. And you can implant it more superficially, so you get a greater effect. And also you can implant arc segments of up to 360 degrees. So you with the same segment, you can just cut it to your desired length, arc segment. Your everything is very customizable right there in your OR. So you can take the kind of plan that you would really like to do rather than be constrained by what is available to you. Indications are many. Keratoconus, you can do it with cross-linking, simultaneous or sequential, or you can do it in stable keratoconus, such as the older patient or already cross-linked patients. You can do it in patients who've got other reasons for corneal ectasias or irregular corneas, and you can also do it in synthetic segment complications. And I'm happy to say that now there are a large number of countries where CARES is being done now. Many centers in USA, Canada, Australia, South Africa, Turkey, Israel, Lebanon, Dominican Republic, Germany, and many, many others coming on and adopting this technique. And of course, us in India having a huge number. This is a Scheimpflug image, which shows the pre and post Scheimpflug of the cornea of the keratoconic patient. And it's been taken obviously along the same axis, centered at the lens at the same point. The anti-surface of the lens of both of them have been aligned, and you can see the flattening that has been obtained with these segments that you can see in the green post-op, and the flattening of the cornea that is obtained with this. Here's a picture that I've taken courtesy Jack Parker from US, which also shows beautiful flattening post-CARES. Again, you can see the CARES segments within the cornea there. And you can see the flattening is just simply obvious. And this is really a beautiful way to explain to the patient exactly what you're trying to do, because this is a conical cornea and here's how we flatten it. And you can also see the keratometric values here with a lot of flattening, and the difference map of the same patient showing even up to 25 diopters of flattening. So this is a beautiful technique, as I said, in advanced cases. You can also, as I'm going to show you in this picture, do it in moderate and mild keratoconus patients. So here's a patient who had about 20 by 120 preoperatively, post-operatively came to 20 by 30, and you can see that post-CARES, this is pre-op, the second picture is post-op, and the third is a difference image. And you can see what has happened here in the post-op is that there's corneal regularization as well as the flattening of the steep axis and steepening of the flat axis, which improves the overall topography. And you can see a huge decrease in the cylinder from -7 to -2.5. And also notice the thicker implants that have been put here as opposed to the thinner in the other eye, which gives you a milder effect. So that's how you can tailor your effect, by changing the thickness of the segments that have been put. And of course, also by changing, if you want, the diameter, the optic zone, the arc length, and so on and so forth. Quickly go through some other examples. Here's a patient who improved from 624 part to 6.9, and again a regularization of the topography. In all these subsequent images, you'll see the regularization of the topography and the decrease in the keratometric values that are seen here. Here are again customizable, as I told you, 330, 340, 360. You can put any kind of arc segments that you want to. Here's an asymmetric segment for a patient with an asymmetric cone, and you can see you can get asymmetric flattening, so inferior flattening for this inferior cone, which can again give you differential results. Again, an inferior cone. This is pre-op, post-op, and the difference map giving you about 15 diopters of flattening with a single segment that is placed below the cone. Again, different images here, but I'll actually go to this image because it's a beautiful one. It shows you how the coma of the patient can be decreased, and so the visual quality can be improved. You can see here the coma in the 6 millimeter zone has come down from 3.438 pre-op to about 0.350 post-op. So you can notice that that's the reason that patients are very happy, because their visual quality really improves. Another example, 3.407 to 0.177. So again, great improvement in coma. This is a website, cornealanalysis.com, which is made by my friend Shady Awad and Jad Asaf. And you can actually use this beautifully to kind of calculate the length of your segment, the arc length, and lots of things that you can do with this website. And I'll advise anyone who is interested in looking at that website to go to it. I have no financial interest in it.
Last 1 minute, Dr. Soosan.
Yeah, I'm done. So the change in segment thickness with time is not substantial in our experience. And we know that also shape change is not really a mathematical calculation, so it's not that crucial. But the reasons I think it does not really change substantially is because of maybe its intrastromal location, and also because maybe cross-linking freezes it in place. And I also know that Mario Nubail has posted similar results with his Slack. These are just other examples of CARES, but what I'd like to basically end with is to say that CARES can be used as an early treatment option. It can be used for bioptics in combination with other techniques. It can be, it's reversible, and you can also use it to replace DALC because you're not losing anything. You actually can get great results. Patient can do well, and you can improve contact lens tolerance, and you can avoid all these complications that can be associated with lamellar surgeries and DALC and even OPKs. So I'm sorry, that's my clock. So to conclude, it's effective, stable, simple, safe, and reversible and adjustable technique with a very low level of rejection because of all the reasons that I've mentioned here, most important being the very low volume of stromal transfer and rapid keratocyte repopulation. And really, in our practice, we found this to be a great addition. Thank you so much.